excited today to have Mary Bayliss as our guest on Chat About Aging in Your Community. Mary has had a fabulous career in healthcare, and I'll let you tell us a little bit more about it, Mary. But at this point, she's also the chair of CHATS, Community and Home Assistance to Seniors. So she has been with our organization for a number of years, has led us through considerable change and growth, and has really been able to help us think strategically about positioning ourselves well in the community to best serve the older adults and their caregivers that we do. So I'm really excited about getting into a discussion with you. But Mary, why don't you just start off with a little bit of a description about your background for everybody who's listening today?
Sure. Thanks, Christina. Delighted to be here. This is exciting. I've never been in a podcast before, actually. So there you go. So I'm Mary, Bayliss, and my background is I have a clinical background as a respiratory therapist for almost 40 years. Coming up to June this year, it'll be 40 years that I graduated. And I've worked in a number of different areas, mostly acute care. But I've also spent some time working in healthcare regulation, so both for my own profession and for physicians. And but my heart really does belong with caring for seniors, and that sort of stems from a position I had when I was managing a transitional care unit at South Lake Regional Health Center in Newmarket, and saw the challenges that we faced when we had patients that no longer needed the care of a hospital, but we were kind of stuck, and stuck with the families about where these clients could go. And so there stemmed my passion, I think, in trying to work with agencies like CHATS, which is when I became very interested in CHATS because of the basket of services that they have to help seniors and older adults live well and stay in their home, which, as we know, most seniors want to do. No one really has a strong desire to move into long-term care. And we know that long-term care is there for clients who really need that full kind of comprehensive care. But most of us want to stay in home. And it's organizations like CHATS that really serve that void. And I've been delighted to belong to CHATS and see the amazing work that they do, and see the thankful families and clients. And so it's just been an absolute privilege to do that.
So Mary, you mentioned transitional care, and for people who may not quite understand that terminology, what does that mean, and what's the impact on the older adults who are going through that transitional care?
Yeah, that's a tough one. So that generally, from a hospital perspective and from home care, it's those clients that come into hospital. They often do have complex care needs. They might have comorbidities, a number of chronic conditions, and they need a certain level of care, but they don't necessarily need any longer, at least. They don't need acute care, so a hospital care. But because of the limitations of what's out in the community, and they kind of get trapped in this conundrum where we have nowhere to put them. There's not enough long-term care beds. But more importantly, and that's my view, is there isn't enough support in the community, because I think some of those clients can easily go to the community, but they might need personal support workers. They may need home care. They may need home supports, like someone that can clean and look after their place, and then just be there so they can be safe. And again, that's what CHATS does with what we have. I think we all agree, even at CHATS, that if we could do more, we would do more. But those clients, it's very sad because the families are struggling as well as caregivers, and sometimes they need respite. Some families, they're in that sandwich generation. You've got younger kids that they're trying to care for, and they have older adults, and they're really struggling. They're really struggling to sort of manage both of those worlds that they're living in. And I think we have a lot of seniors that are falling through the gaps.
Mm-hmm. Yeah. Sadly, I have just recently had two family members who lost parents, who came into the hospital as a result of a fall,
Yeah.
broke their hips, had hip replacements. All of that went well, but the frailty of the individuals, they're both women in their 90s, and the frailty of the individuals really indicated that they wouldn't be able to go back home unless they had those supports available. And my family members were just reaching out to say, what can we do? How can we get them home? Is it
Yeah.
even possible that they could come home? Unfortunately, those supports, partly because of where they live, were
Yeah.
not available to them to enable them to come back home. And unfortunately, both passed away in the hospital, which is unfortunate, because that's not
Very.
really the purpose of the hospital, nor an ideal place for somebody to complete their journey. And
Yeah.
organizations like Chats and so many others similar to us are advocating strongly for recognition that we need more investment in
Mm.
ensuring that people at the end of their lives, or even as they are in their older ages, have the support or have the choice, right?
Well,
For some
that's it.
people,
Yeah.
it may
Yep.
be their choice to live in institutional facilities or in retirement homes. For others, that's not, as you said earlier, that's not really where they want to be.
It's not where they want to be, and it's not where they age and have a good quality of life. I mean, that was some of the difficult conversations that I had to have with families, is that hospitals are no place to live. Like, hospital settings are not set up to provide the enrichment. We are there to provide care for patients when they're acutely ill. So when they're over their acute illness phase of their journey and their recovery, they do far better out of the hospital than in the hospital. In the hospital, they're at risk for infectious, diseases, and there's just no enrichment. Like, we don't have, congregate dining settings. I remember we tried to do that when I was at one hospital, but as the community grew and as we ran out of space, because most hospitals now are at over 100% occupancy, all those additional spaces in hospitals become hospital rooms, hospital beds, even though they weren't designed to be that. And so that removes any type of area that, like gyms, every potential area gets filled with beds to care for patients who are acutely ill. So it's in every patient's best interest that once they're past over that acute phase of their illness, that we get them out. But we get them into a place that is congruent to their continued recovery. And we do know there are studies out there that show that patients do much better once they get home. They're in a familiar environment. Elderly patients are at risk for delirium. And we know in hospitals, even if you're just simply over the age of 75 and you get admitted for more than a day, you have a risk of developing delirium. And that delirium will cause confusion and often can result in falls. And we know a fall in a certain population can be catastrophic. You can get head injuries. I mean, quite apart from the broken hips, which that in and of itself is terrible as well. But some people fall and hit their heads, and then that's a whole other basket of problems. But I think if we had more supports in the community, where we could get those patients home and do that, what Chat does so well, that wraparound services, the
Mm-hmm.
home maintenance, Meals on Wheels. Again, for those who are listening and don't know, one of my favorite programs at Chats is Home at Last, where if family members are at work, for example, and patients are discharged from hospitals, Chats will come and pick up the patient from a hospital and drive them home and pick up some groceries maybe along the way, get them settled, put on the kettle and make them a cup of tea, and just make sure the home is safe for them. And that may not sound like a big deal, but it is a big deal. It is a big deal to have them safe. And that's just one of many programs that Chats has. And I can tell you, you mentioned earlier, the one piece I don't want to miss on this, I come from Northern Ontario. And when my mom passed away right in the beginning of the pandemic, not COVID related, but that's when she passed. She had been sort of homebound for a number of years, and there isn't a Chats up in Sudbury. There wasn't that level of care, which made it very difficult for me and other family members who were living, hundreds of kilometers away, to try and get her the right service. And that's just one small example. We know there's inequities across the province and across the country, and it would be, I think we really have to address that inequity. It's not, Chats, even Chats does an amazing job. We know we could do more with more resources, with this population that we have in York Region, which is growing all the time. But there are areas of this province who don't have any Chats and don't have any of those services at all.
Mm-hmm. And it's not just an issue of putting more money, although that is important to have that investment. There's also challenges with having enough health human resources.
Oh.
So, as the population ages, people do want to be able to age at home with the supports, but we really have a challenge. We're facing a catastrophic challenge, I would say, in having enough people who are available and able to do that home care support.
Well, yeah, and we have to level the playing field, because we also know, those of us who've worked in the industry and in this sector, is that, again, talking about equity, there's inequity in how we compensate, and therefore, I would argue, how we value the care that is delivered in the home and in the community. So we have a certain pay grades in acute care, and then we have a different set for the community. And it's very hard for, and this is where I think Chats does an amazing job, because we've had PSWs that have worked for Chats for years, and they're loyal to the organization because Chats is loyal to them and treats them with respect. But it's very difficult. Like, I think there's a big emphasis now on recruiting from overseas. Ethically and morally, I sometimes have a little bit of an issue with that, because this is not just a Canadian problem. This is a worldwide shortage of health human resources.
Yeah.
I would love to
just pulling people in just creates more pressure somewhere else.
So all we're doing is stealing from Peter to pay Paul, or that saying. What I would like to see is more emphasis placed on retention of your existing staff. So compensating them fairly and equitably across the board, regardless of where they're working. Having one standard scale that applies whether you work in long-term care, in home care, in acute care. Same scale. They're doing the same valuable work. A PSW who's working in the hospital is doing the same type of work that they're doing in a home, and it should be compensated the same. So I think we should be spending more time on retention. We have a lot of people a lot of health, healthcare workers that left during the pandemic because it was so difficult, and they worked under, extraordinary conditions, and they left their profession, but they're still around. If we did the right thing, we can draw them back. If we, had a concerted effort to look at how do you pull back those folks that left us in the middle of that pandemic, or at the end of the pandemic, or whatever the case may be. But I think there has to be more on retention versus just recruitment. Increasing, the school, increasing those allotments into school programs. I think that's good too. Doing some homegrown educating of healthcare workers. But this reliance, to me, on pulling in internationally educated, and I'm not against immigration, don't get me wrong. I have no issue with people who want to come to work in Canada. They want to have a better life. And I mean, I've worked abroad. This is a wonderful country. That's not the issue that I have. I just think right now there seems to be this big focus on, let's just pull in from other countries and make it easier for them to get licensed and work here. And while that might be some of the issue, that's not going to solve our other issues. And this week at Chats, we had a meeting about, some of the agency, this notion of organizations having to rely on agencies, staffing agencies, where, people have figured out, I can get employed at a hospital or chats, or I can go and work for the agency and make a lot more money. But then that's causing the system. That's going to collapse our system and bankrupt our system if we don't take measures to stop that.
Mm-hmm. Mm-hmm. And we will have some guests on other podcasts to talk about some of the experiences in other jurisdictions, other countries. One of those jurisdictions is Denmark, and the Scandinavian countries are often held up as an example of where they've really figured out elder care and
Yes.
being able to support people to live in their communities. And one of the things that they acknowledge is that, as you said, the health human resource shortage is not just something Canada is experiencing, it's everywhere.
Yeah.
So they've started to look more as well at how technology can be used to support, not replace, but support human activity, some of those manual activities. And have you had any experience with that and sort of thoughts in that direction?
Well, I don't have a ton of experience, but I know at one point when it was like pre-OHT, the Ontario Health Teams was Health Links. And we worked a little bit together on that, Christina.
We did. I think that's where we met. Yeah.
That's where we met. And, we were looking at different technologies that could help people live at home, that like a virtual monitoring, but there's other systems. There's technology out there that people can wear that will alert themselves and others if they're at risk. They can tell if they're out of balance and there's a risk for falling. So that's just one example, where there's wearable technology, there's infrastructure in your home technology. People can be watched, you can have cameras up and have virtual monitoring. You can connect with people. So there's all of that technology, but I think that is the area that is going to be available to help us. If we don't have enough bodies, then you can certainly have technology that can maybe be doing some of the same things. You still need that personal touch of a human being, but for sure there is likely technology that can help us. And when you brought up Denmark, you're right. I mean, there are some countries that really have been quite innovative in what they've done, and they've broken out of the norm. This norm that I think we've fallen into this this cycle within, especially in Ontario, where it's like it's either or, like you're in a hospital or you go to long-term care, or you go to the home. Like, we're not thinking the NORCs or, the naturally occurring retirement communities are another example that, I think there's jurisdictions across Canada. I think it was it British Columbia, that are looking at replicating some of those, where there's a home and then you have people that are, anyway, I think there are so many different things that we can borrow from other jurisdictions that are maybe a little bit more innovative, or at least they're trying to some of these other things that we could look at, rather than just falling into this. It has to be either or, long-term care or home. I think there's other options for sure.
Yeah, definitely. And I think that you mentioned the personal touch. We have to remember that a big challenge for a lot of older adults is that they don't have that connection. Loneliness is an epidemic.
Huge.
Loneliness can lead to so many other challenges for individuals, not just older adults, anyone, but certainly when somebody gets to a point in their lives where they've lost friends and family and are the only one left, that becomes something that can affect their mental health, their physical health, and often we may not even know where those individuals are. CHATS, of course, does have a number of programs that are designed to address social engagement, a very big part of enabling people to be able to continue to be a part of their community and stay active as possible in their community and socially engaged. Have you got any thoughts on sort of the loneliness and what we might be doing more of?
Well, I'm glad you brought that up because, and the other thing that I saw this week, so everything, yes. I mean, I think some of the programs that we have, not only the adult day programs where we get patients that may have dementia out of their homes and interacting and being active and trying to stimulate their mind and their bodies. But yeah, those, the phone calls that we do, where we reach out and talk to people, the culturally specific programs where they can come out for lunch and chat with people of their home country and the language that they're most comfortable with. But recently, the ministry released, Ontario Health, I should say, released the social determinants of health and an updated document and a framework that talks about all of those elements of social determinants, which is so nice finally for that to be taking a little bit more of an emphasis, because we know it's not just health. It's the whole person, and it's their community, and it's all those things that interact about how well they do and how well they can stay at home. There's also a lot of work being done. The last group of people that I worked with, family physicians, there's a lot of talk about social prescribing now. So, you go to see your family doc and you're there for your upper respiratory tract infection and you're looking for antibiotics, or you're looking for the antidepressives. But there's more now this emphasis placed on social prescribing and the benefits of getting out and interacting with others and the benefits of exercise. We know that there's great evidence that looks at, there's even been controlled studies that looks at, a 30-minute walk versus an antidepressive.
Mm-hmm.
And the 30-minute walk every day is as effective as taking an antidepressive if you have depression. So I do feel like the tide is changing a little bit, where we're looking beyond the standard traditional treatment modalities like medications. We're looking at things like social prescribing, and we're looking at the social determinants of health so that we can address all those other factors that we know contribute to seniors' health and seniors' well-being, I guess, especially if they're at home on their own. But we need people getting locked away on their own. That's such a risk. And it's tough on families who are not there either, right? I've had friends whose parents have lived alone and they want to stay living alone. They're quite adamant. My mom was the same thing. My mom did not want to go, even though, and she didn't want anyone coming into her home. It was very, very challenging to meet her needs and respect what she wanted, and at the same time recognizing that she needed help. And it was very, very tough to sort of come up with that plan, but especially from afar. So yeah, I think I'm rambling a little bit, but I think yes to all of that. I mean, we need to address the whole person.
Yeah. And certainly, looking at ways in which we can support people to feel welcomed
Yeah.
and included.
Yes.
And to your point, it's not like you could just sort of force somebody out of their home and
Yeah.
say, "Come along, and we'll have you involved in chair fit yoga and
Yeah.
playing games and that sort of thing." But at the same time, I think that we need to look at ways in which we can identify those individuals who are perhaps at risk or experiencing loneliness and work with them to determine what their objectives would be and how to become engaged. So very important. We've got a few minutes left, but I do want to touch as well on something that you mentioned with respect to the social determinants of health, which includes, not only physical and mental well-being, but also economic well-being.
Yeah.
And, we are facing a very difficult time, again, not just for older adults, but across the board, with the lack of affordable housing,
Yes.
with, the cost of living has increased significantly, post-pandemic. Interest rates are coming down now, but, things have been a challenge economically for people. But the area that I think we also need to look at is the housing itself
Mhm.
and affordable housing. Have you got any thoughts on that?
I wish I have lots of thoughts. I don't know that I have solutions. I think we always talk about the fact that we don't have affordable housing. Um, York Region's an interesting place as well. I think it's unique because, and I think you mentioned this the other day, Christina, where, we have areas in York Region that have big houses, like big kind of mansion-like homes, where, we might have one senior living in a 5-bedroom home, and it's their home. And yet we have very few affordable bungalows. I'm going to give you an example. Bungalows, affordable, where, some people do want to move in when they get to a certain, even, I'm about to move into a bungalow, thinking about, the next 25 years of my life, and not, wanting to have something that's more conducive as you age. But we don't have a lot of that available. But we have a lot of homes that could be repurposed, I guess. That's, one of the things that I was thinking is, if you had, instead of thinking long-term care or assisted living or retirement homes, some of these big homes could house 5 seniors, where they live with, one PSW that pops in and is able to care for 5 clients, and maybe a homemaker that comes in is able to help with meals. But maybe there's a level of independence there that they don't need to be in a long-term care necessarily. A nurse, if they're diabetic, a nurse could come in once a day and help the diabetics with their insulin. I just think there's probably other models out there. And I think this model has, actually, I'm not making this up. I think this is a model that may come from Denmark or one of the Scandinavian countries that I've read about. So I think these models do exist. I think there's other issues in other areas of the province that have that are, span a large geographic area and territory, and that creates a whole other host of issues and problems. And I don't know that anyone's been able to tackle that. When you think about Northern Ontario, where some people just to go to the hospital is over an hour, it could be 2 hours to get to a hospital. And the shortage of primary care everywhere. Primary care used to be a Northern Ontario problem, and now it's an all Ontario problem, or I would even argue all Canadian problem, where we don't have enough primary care. And I will say this again, and those who've known me for a long time, I've harped on this for many, many years, that I also think there's underutilized healthcare workers out there. We've talked about interprofessional collaboration, interprofessional practice, where we allow other professionals to practice to the top of scope. I still believe there are many professionals out there who are pigeonholed into a certain area, and because of territorialism and turf protection, they're kept in their corner and not allowed to branch out to actually fulfill their full scope. My profession, I believe, is one of them, respiratory therapy, where I think we've worked in certain areas and we've been allowed to practice in those areas, but there are other areas where our skill set has not been tapped into, and that's a shame. And we're just one profession of many who I think could fill voids if we thought a little outside the box and created that. I mean, nurse practitioners is another great example, where some are now opening up private clinics because they fall outside the Medicare and OHIP model, so they can't bill OHIP for their services. But we need primary care, and there's a lot of nurse practitioners that could jump into primary care and really ease the burden. There's I think it takes a bit of courage, and it would take the government to really say, yes, we can. Same with home care, home and community services, that there is money to be saved. We know there is. It's just a matter of trying to, and I know they're trying to do this with OHTs, and I think that is the direction to go. It's just taking a long time. Pandemic didn't help. In fairness, the pandemic
True
didn't
enough.
help.
Yeah. Well, Mary, I want to thank you so much for being our guest on Chat About Aging in Your Community. You've had just a wealth of thoughts and experience to bring to this discussion. Really appreciate it. Appreciate so much your commitment to chats over the years as a board member and as chair of the board of directors. I want to thank you so much. And I hope that people have got some new ideas or some new thoughts about how we can really ensure that older adults can age well and be well and live in their own communities.
Thank you, Christina, for inviting me. And it was always lovely to chat with you about this topic that we're both so passionate about. So thank you for having me.
Thanks. And thank you to all of you who have listened to us today. And we hope that you stay tuned to our next podcast and some great guests coming up. Thank you.